A very good afternoon to all professors, doctors, and fellow medical professionals. Thank you for taking time to join us in this second webinar in the Safe Prescribing Solution series titled Tips for Prescribing Educators by the British Pharmacological Society Assessment. Hosted by iGroup. We are particularly delighted to have participation from Indonesia, Thailand, Vietnam, many other APAC countries, and particularly Malaysia. We have many registered from Malaysia, and they come from a wide variety of institutions like MASA, RCSI, UCD, IIUM, Nottingham, UCSI, USM, Monash, Cyberjaya, to name a few. So thank you very much for joining. I'm Dr. Olivia T, your host for this session, and I'm from iGroup. iGroup is a one-stop station for information products and library technologies. Our ability to provide a full spectrum of related products and services with localized support from each of our regional sales offices establishes us as the key information industry partner in the APAC region. Now, recently, the WHO has initiated the third Global Patient Safety Challenge, and we are perhaps all quite aware of this, called Medication Without Harm. According to the WHO, unsafe medication practices and medication errors are a leading cause of injury and avoidable harm in the healthcare systems across the world. And globally, the cost associated with medication errors has been estimated to be about 42 billion US dollar annually. So Medication Without Harm is an initiative aiming to reduce severe avoidable medication-related harm by 50% globally in a period of time. It was suggested to be 5 years, starting 2017. So today we are honored to have representative from the UK to speak to us about some solutions available to support prescribing safety and patient safety, mainly in education, but also to some extent in clinical practice. So I would like to first introduce Professor Simon Maxwell to everyone. Perhaps he's not a stranger to many of us. He's a physician based at the University of Edinburgh, who specializes in clinical pharmacology and prescribing. He has led several UK national initiatives focused on better education and training in safe and effective use of medicines, which will be the focus of his presentation today. He is also the medical director of the Scottish Adverse Drug Reactions and has served on the National Institute for Clinical Excellence. So today, we're honored to have him to share with us some tips on how to teach prescribing effectively, what are the expected competency in the prescribing curriculum, and also how to assess prescribing competency. So before we proceed, I would like to encourage everyone to either use the raise hand function. If you wish to speak, we will unmute you, or type in the Q&A or chat tab, and we will attempt to answer all questions at the end of the webinar. And all participants who complete the feedback survey at the end of the Zoom session will receive a 1-month free access to the resource of your choice, in this case, the BPS assessment platform. So I'll hand the floor over to Professor Simon.
So thank you very much, Olivia. Thank you to iGroup, and it's a delight to be talking across the globe again to the region. Thank you also to so many of you for giving up your time in the afternoon just to listen to me. The topic that I'm going to talk about is actually pretty enormous. We could speak for the whole day, and in fact there are whole meetings based around this topic. So I'm really going to move fairly quickly through a number of aspects of it. I'm joined today by Dr. Marcus Hughes, also from the British Pharmacological Society, and I think if there's any follow-up at all and we don't manage to talk later on, then do please feel free to contact us if you wish to follow up on anything that I've said. We're going to talk, I think, a little bit about the background, and Olivia's touched on some of the challenging issues, particularly what's happening in healthcare, some of the evidence that is available about what's happening in relation to prescribing medicines, and the kind of training pathways that we can plan to improve things. And I'm going to clearly focus on sort of outcomes, learner resources, and assessment. So let's just focus a bit on the background to what we're trying to do and some of the challenges that we face when we are looking to try and improve education in this particular area. I apologize in advance if anybody listened to the last seminar, because there are some crossover slides, just like this one, where I pointed out really that prescribing medicines, core business for healthcare in all parts of the world, particularly if you work in hospital, but also in the primary care sector or the community. It's the main way that we actually treat disease, improve symptoms and prevent disease for the future. Certainly here in the UK, the majority of what happens is appropriate, safe and effective. But the reason we're all speaking today, and the reason why education for better prescribing takes up rather a lot of our time if we're involved in the training pathway at undergraduate or postgraduate level, is that there's a measurable rate of error. In the UK, that's around 10% of hospital prescriptions contain an error of one sort or another, and it's around about 5% of primary care prescriptions. And when we talk about error, we're talking about prescriptions which are not delivered effectively or timely, aren't necessary, and have a reduced chance of actually being effective and an increased chance of causing the patient harm compared to what would be accepted best practice. There's also a number of avoidable adverse drug reactions. Adverse drug reactions happen to all of us. Anybody who uses a medicine, inevitably, even if they do it as well as could be expected, from time to time there will be an adverse reaction to the medicine. But unfortunately, sometimes those adverse drug reactions could be avoided with more just judicious use of medicines. And we reckon probably about 6% of admissions to hospital here, unscheduled admissions, relate to adverse drug reactions. And once you're in hospitals in the UK, you've probably got more than a 10% chance of being affected by an adverse drug reaction that will prolong your stay, increase the costs of healthcare. So for all of these reasons, if we're interested, and I hope we are all interested in improving the quality of the healthcare service that we deliver, then focusing on better and higher quality use of medicines has got to be part of that. Medicines aren't everything, but they do count for a lot of what the healthcare service does. And of course, they're a major investment. I'm not sure what the proportion is in the countries you all represent, but in the UK, the medicines bill is between 15 and 20% of all of the resource which goes into healthcare. So it's enormous. Of course, it's not my place to describe best what's happening in your region, but there are a number of studies that have come to light that have focused on the same kind of things I've been focusing on in the UK. So this was prescribing errors at a tertiary care centre in Malaysia 5 years ago now. Around about 4% of the prescriptions were felt to have errors. There were plenty of other studies, both in Malaysia, but a lot of the other countries in your region that show that prescribing errors, just like they are in the UK, are fairly prevalent. And I thought a particularly good systematic review by Samarsi et al. from about 8 years ago now showed that the error rate in the various countries mentioned there varied between 7% and 35%. And of course, the variation that is reported in studies is partly due to the fact that the definitions of a prescribing error are a little bit different in the different studies that you apply. But I hope I've made a case to you that there really is no reason for complacency here. It is a major issue in healthcare if we're going to improve quality. And I noticed in the quick guide that I think is prevalent and issued by the Ministry of Health in Malaysia, there is a lot of focus about how we can make things better in Malaysia. We shouldn't be surprised, really, that error is so prevalent. I think most of you, like myself, are educators, and maybe, like me, you point out to your colleagues, this is actually the most challenging task that we expect our junior graduates, those people who've just left our medical schools and start to work within the hospital sector, certainly in our training program. This is about the most difficult thing we ask them to do. They have to make a diagnosis. They're entrusted with a patient. They have to make a diagnosis. And sometimes, of course, the best you can do is make a differential diagnosis. It isn't absolutely clear when the treatment starts as to what the final diagnosis is. And based on that presentation, history, examination, investigation, findings, you have to write out a prescription, which includes the details of a medicine, the dose it's going to be given in, how it's going to be given, the route, how often it's going to be given, and for how long it's going to be given. So that's a challenge enough, but some people would point out, well, you can go to a textbook or a formulary to find out that stuff. But the reason that we can't just send anybody out to be a doctor or a prescriber without several years of training is that there's a lot more to it than that. That prescription has to be formulated in the background of infinite variability because of the different age, sex, and genetic background of patients, the different diseases that coexist, and the interacting drugs. And increasingly, we're expected to deliver shared decision-making with our patients, and so patient preference is becoming part of that. Having agreed everything with the patient, our prescribers, the people we train, have to be able to counsel the patient and advise them best about their medicine so that the medicine is used as effectively as possible, but also importantly, that the warning signs when things are going wrong are highlighted at the earliest opportunity. And in addition to that, the prescriber also has to understand how to monitor for the effects so that they can work out at an early stage themselves whether there are signs that the objectives of the prescription are being met, or whether indeed there are signs of emerging problems that suggest that the prescription should be changed, amended, or stopped altogether. And of course, if we look at box 2 on the left of my slide, it's clearly going to be important that in undertaking those tasks, we have prescribers who are knowledgeable, have the appropriate skills, can make judgments when issues are relatively grey and there are competing factors. They have to be able to communicate them, and ideally we'd like them to be experienced in prescribing, and maybe I'll show you some data later on to suggest that we could do better with that. And of course, all of this is going on in the face of some of the problems in box 3, which is that the systems that people that we train go out to work in are not perfect by any means. So as a clinical pharmacologist myself, as Olivia kindly pointed out, I would say that a sound grounding in clinical pharmacology as a basis for making good decisions is really important. Even if you don't call it clinical pharmacology in your course, it's the basic science underpinning rational use of medicines, and it needs to be there and represented. And of course, our graduates are actually working in a more difficult setting and scenario than when I graduated 40 years ago. The throughput of patients is higher. The vulnerability of those patients, because they tend to be more elderly than they used to be, is greater. The graduates have a formulary that's got a lot more medicines available to prescribe. The treatment regimens are more complex. The patients themselves are taking many more medicines. When you get to my age here in the UK, then you're likely to be on at least 3 or 4 medicines and probably a lot more. And that increases with age as the background diagnoses increase. We've also got a proliferation of guidelines and advice and expanding evidence base. And finally, the patients, as I mentioned already, expect a lot more and clarity in the advice that they receive. So we could now go on and talk for a long time about systems factors and how we could make our hospitals and practices better and provide more help to prescribers. But I think we have to recognize that the system is never going to be perfect. There are always going to be problems with it, and we should act a bit like the aviation industry and the nuclear industry and expect there to be a suboptimal system that our prescribers go out to work in, and therefore we need to make sure that on the left of this slide they are resilient and able to cope with the fact that people are going to be asking them to multitask. They're going to be given rather a lot of different things to be done in a short period of time. They're going to be distractions. Sometimes all of the information that they might wish to have is not going to be there. So we've got to equip them with all of those skills and knowledge on the left-hand side, and we have to work out how best to do that and how effectively. And I spoke a bit last time about all of the other things that we can do to improve systems, technology, pharmacy, and improvements, other improvements in working system. But it clearly today I want to focus around the training process, both in medical school and perhaps beyond. And I'm not trying to say to any of the 27 participants that have kindly joined me this afternoon that I know the solutions or that the UK has got to the bottom of all the solutions, but I hope you will be interested in some of the things that Marcus, I and our colleagues at the British Pharmacological Society have tried to do, because clearly prescribing errors are an issue in your part of the world, just as they are a challenge for us. So I'm not sure how many of you are based in medical schools. I'm based at the medical school here at the University of Edinburgh, as well as working as a physician in the healthcare sector. But I spend quite a lot of time. I lead the program in our medical school, and I have around about 35 colleagues elsewhere in the UK medical schools doing exactly the same. Now, we faced a bit of a challenge, and amazingly now it's about 30 years ago when our medical regulator here in the UK, the General Medical Council, or GMC, published an education document which completely altered the way that we deliver this kind of education in the UK. And what they wanted to do was to reduce the factual burden that had built up in the various education programs which had run for decades, possibly doing what they thought was best. They sought to find a lot more integration. So rather than lots of different disciplines and ologies represented by the colourful bricks at the bottom left, they wanted to merge things together, so there was a better relationship between anatomy, physiology, biochemistry, and pharmacology, and it all came together rather than being separated. They wanted it to be much more system-based and problem-based, and they explicitly said in paragraph 42 that they wish to avoid all reference to traditional subjects and disciplines, urging the advantages of interdisciplinarity. So there was quite a lot of good things that came out of that. There was no doubt there was an unreasonable factual burden. But for those of us who were pursuing traditional subjects like pharmacology and clinical pharmacology and ologies, particularly those that had actually inevitably quite a high factual burden, I'm afraid this process was very challenging indeed. So we went effectively from having what you see on the left-hand side of the slide here, 5-year course roughly in the UK. We had pharmacology courses and pharmacology exams, clinical pharmacology courses and clinical pharmacology exams, and therapeutics courses and therapeutics exams. And you know, there was no chance that a medical student in the UK at that time would not know what pharmacology was and clinical pharmacology was, because they'd actually have courses in that area. Well, tomorrow's doctors really changed everything and brought us across to what you see on the right-hand side of the slide, which was where all of those individual courses marked in blue disappeared, as did the identifiable exams, and it was all sort of mixed up into a much more integrated passage. You know, I fully accept that, but of course it meant that the visibility and the clarity for the learners as to where the disciplines related to drugs and medicines, where they'd actually gone to. So that, I think, represented a great challenge for the community trying to do the teaching in this area. And rolling on 15 years from that, you know, I did this sort of study amongst medical students in the UK. It was by no means all of them, probably only about a quarter of them over the 4 years that were identified. But the challenge was that they themselves, this was, I didn't try to tell them what to say. We offered them to describe their teaching in pharmacology, therapeutics, and prescribing as either far too much, too little, far too little, etc. And you can see that nobody thought it was far too much or too much. About a quarter thought it was just about right, but 3/4 thought that there wasn't enough. And the reason they thought that was because they could actually see what was happening on the wards around them that they were heading towards working on, and they could realize how much was related to medicines and how little that they were actually getting. There were other signs at about the same time in the year of 2008. This was a study which was done. I had nothing to do with this. This was just looking at various different interviews with junior doctors who were just out of medical school, and you can see it says there was a consistent thread from the primary sample of underpreparedness for prescribing. Weaknesses were identified in pharmacological knowledge underpinning prescribing, practical elements such as calculating doses. And the very bottom paragraph here, they even applied a very small assessment to the graduates of 2 schools, and fewer than 1 in 5 of them passed it. So that, I think, hopefully sort of focused a few more minds that there might be a problem. And you know, it's interesting. You know, I've been talking a lot about the UK. This is the United States. Just about sort of 7 years ago, a group of educators got together, did a similar study, and they also found that there were concerns that there was not nearly enough prescribing education and education in the clinical pharmacology area going on. So this isn't just something we've been struggling with. It's been an issue that's been found in other parts of the world. So there are lots of studies, and we could talk about them, but thinking about those studies focusing on the UK, the key messages were it's new doctors, the people very shortly out of our hands as educators in medical schools who do most of the prescribing. Shouldn't be that way, but it is that way. They tend to do a large proportion of the prescribing on the wards in our hospital. They feel underprepared for it. They tell us they don't get much practice during the training process. It's the part of the job that they fear the most. And when you sort of papers that looked at what the trainers thought, the people like you and I working in the hospitals and supervising those medical graduates, they thought that prescribing was a skill that required further emphasis. And so I showed this slide last time, a couple of weeks ago. So essentially, this was the path seemingly that too many of our graduates were on. So they weren't really getting to the basic competence stage by the time they graduated and became a trainee doctor. And really my mission for much of the last 20 years, and particularly working with the British Pharmacological Society, has been to try and improve the learning curve so that when our graduates actually step out of medical school and actually sort of arrive there on the wards of the hospital, that they're much better prepared. I've no doubt that everybody will get with experience to where they need to get and has been doing for some time, but we really need to make sure that there is faster learning to be able to cope with the increasingly complex environment. And I'll sort of really just highlight sort of ways that we have tried to do that here in the UK. So I was part of a safe prescribing working group on behalf of the British Pharmacological Society in that year of 2008, and that brought together the regulator, the General Medical Council, but it also brought together the medical schools, representatives of the hospitals, the postgraduate training process, the British Medical Association, and the National Prescribing Centre. And I wonder if there's been a similar meeting or discussions where you are in the countries that you represent. And very briefly, that working group, which worked over a sort of a couple of meetings, really decided that if we were going to chart the way forward to improve things, we had to agree on a few things. Firstly, there had to be some defined learning outcomes. It's amazing, but at that point, when medical schools were trying to skill up their graduates to be able to take on prescribing, there weren't really any clearly defined learning outcomes that said that this person is trained to the basic level to be able to become a prescriber. There was no list of medicines, there was no list of skills, etc. So it was quite clear that there had to be a much clearer definition of defined learning outcomes. The next thing was that we had to work on a national strategy to improve the training pathway and support students as they attempted to reach the outcomes in the first bullet point. We needed then a reliable assessment that would allow students and their schools to demonstrate the learning outcomes have been met. And, we wished to do that on a national level rather than every single medical school just marking its own homework, to use an expression which is quite common here. We also felt there should be unified prescription charts, and a number of efforts were put to try and make sure that as you moved from one hospital to another, you didn't change prescription charts. That's kind of been taken over now because, of course, electronic prescribing is growing very quickly, and sadly there are a number of different electronic prescribing systems out there which make things complicated. And we also thought that it was very important that we improve training and access to the British National Formulary, the BNF. And we're very fortunate here in the UK that we do have a national formulary that actually is available to everybody. It was issued in paper form for about 60 years, and it's now, of course, all in an online form. And if I have the opportunity, Olivia suggested that I might show that to you, so for anybody who's unfamiliar with it a little bit later on. But clearly, that's what all prescribers work with in the UK. And unfortunately, a lot of our undergraduates were not very familiar in 2008 with the British National Formulary. And so to make them sort of more aware and more competent prescribers, clearly helping them with the basic resource that everybody uses, make them familiar with it, was going to be very important. So most of you are educators, so you'll see that really those top 3 bullet points are very standard educational approach. You set the learning outcomes for the program, you provide the training pathway and the learning opportunities, and then you assess that those learning opportunities have been met. But you know, what we were trying to do here in the UK was to make it a much more coordinated approach, rather than having 35 different ways of doing that. So what about defining prescriber competencies? Well, you know, I think that's really important, and it may be that you've all got your lists in your own countries, but for us it really started with what are the demands of being a junior prescriber working at a basic level in our hospitals. You know, before you can set what the learning outcomes are, you need to work out what is actually being asked of junior doctors working on hospital wards here in the UK, and what's the workload and the degree of supervision provided, and other resources. So you have to understand, one, if you're going to be able to do this process. You can then clarify what the knowledge, skills that might be expected at graduation, what they actually are, and that clarification is very important for medical schools, but it's also, of course, important for the people who employ the doctors when they graduate. They need to know what they're going to get in terms of a junior prescriber who's just stepped out of medical school. So that is really important. So that's what, you know, I'm talking about. But that is important because if you've worked out the knowledge and skills expected at graduation, then you can design the assessments that demonstrate that. That's item 3 in this simple schema. Once you know 2 and 3, you can then decide, you know, can you put in place the learning environment that will actually lead on to be able to pass that assessment and have those knowledge and skills. And of course, then as researchers, all of us, we can start to do research and decide, you know, how well we've managed to link the learning to the outcomes in the assessment. You know, basically how good is our program, and can we actually, you know, are we actually doing what we need to do? And we can then very excitingly start to do things that researchers in education never get around to doing, or at least not as often as they should, work out just exactly how what they do within their medical training environment relates to what's actually happening performance-wise on the wards. And that doesn't just apply, by the way, to prescribing, but of course prescribing is what hopefully is of interest to all of us today. So you can do interesting research then that links you know, the sort of knowledge and skills expected at graduation, or the assessments to prescribing performance. And indeed, you can then sort of relate, you know, the learning program to prescribing performance. So that's what we would like to achieve. And there are still challenges, because how do you measure prescribing performance? It's increasingly possible now that we use electronic prescribing systems, but still the data on this granular enough to go down to individual learners and individual prescribers is a challenge. But it's a challenge hopefully I will continue to work on in the remaining years that I have. So I'm not going to actually go through any of these documents, but just to say that the learning outcomes, they have been published. They've been published by the General Medical Council in the UK and in an even more granular form by the British Pharmacological Society in the document on the left. And indeed, we're just updating that. It's been far too long. It's 10 years since we produced the last major document that outlined the core curriculum for clinical pharmacology and prescribing in the UK. But the Royal Pharmaceutical Society, who act on behalf of prescribers, on behalf of pharmacists, have also produced a competency framework for all prescribers, because here in the UK now it's not just doctors who prescribe. A small but increasing proportion of prescriptions are written by pharmacists, nurses who've gone through sort of prescribing conversion programs. So those are the core learning outcomes. And I note that since we did that originally back in 2008, there's been an initiative which I been involved with to try and do something at a European level as well. So learning outcomes important. So what about learning to prescribe and the training, particularly focusing on medical schools? Well, all of us have a real challenge in this area. At least I think I find this challenging. Firstly, we're in charge of a very knowledge-rich area of the program, and we're in an era when students are not supposed to be overloaded with factual knowledge, but the area that we operate in, you can't get away from it. It's very heavy on facts and knowledge. Even if you try and sort of distill things down to the very core medicines that our graduates need to know about, you can easily get to well over 100 of those, and then within that you're going to have to expect students to know a little bit about mechanisms, pharmacology, sites of action, mode of action, and adverse reaction. So there's a lot going on there. It's also an area of rapid change. I suspect, not that I'm as intellectually capable as I was when I was 21, but I suspect the anatomy that the students get taught about today is likely to be very similar to the anatomy I got taught about, because evolution doesn't move so fast that we're not dealing with exactly the same anatomy we were 40 years ago. But unfortunately, you couldn't go back and look at my notes in pharmacology and prescribing, because the whole prescribing scene has changed. We've got hundreds of drugs now out there on the wards that didn't exist and weren't available when I graduated. So this changes very quickly. Another challenge that I think everybody has in this area is it's difficult to gain prescribing practice for our medical students, because we live in an increasingly litigious era, certainly in the UK and in the United States. It's difficult to let students get too close to what's going on, lest the hospitals that they're training in find that they're challenged because of poor practice. So it's not easy to get actual prescribing practice. It's an area which is cross-cutting through the curriculum. So I've highlighted that the way we deliver our curricula has changed greatly in the last 30 years. The picture in the top right, and it's quite challenging even for an enthusiast like myself to be able to see all through the 5 years of the curriculum where the things that I'm hoping are going to be delivered are actually being delivered. And of course it's really difficult because using medicines integrates knowledge, skills and judgment. So there's an awful lot things which we're going to have to try and train for. The European group I'm part of sort of did an interesting study recently and looked at the training pathways for clinical pharmacology and prescribing in different countries. And whereas the UK, the Netherlands and Sweden here in the UK region had moved over to much more problem-based and active learning, there were still sort of large parts of Europe that have mainly traditional programs of didactic teaching through lectures, and I think that is a challenging. That same study looked at the breakdown of modes of learning, and you can see there's still an awful lot of lecturing going on and expectations of self-study and seminars, whereas the amount of bedside teaching, real-world prescribing, simulation and e-learning at that point, and that's 5 years ago, 6 years ago, was still perhaps not as much as we would hope that it might be. And so I think we need to think overall about the styles of our curricula and the styles of learning, and I hope actually we'll have a chance to discuss that and me to learn a little bit about your experience later on. So better prescribing experiences. Apologies, I did show this slide before, and thinking very much of medical schools pictured in the top right there. So we need learning outcomes. I've said that already, but we also need leadership and visibility. We need people who are actually going to be enthusiastic about this area and committed to trying to make sure that all of those learning outcomes are delivered, and be a conduit to the rest of the faculty if in fact those things are not being delivered. I'd like to think in my own program here I deliver that leadership and visibility for the students, but hopefully you are all acting in a similar capacity. There's factual burden, there's no doubt, and this is difficult for the students to get to grips with, and so we believe very much in student formularies. So that is trying to sort of distill down the thousands of drugs that are listed in the British National Formulary down to the 100 to 150, which are the most commonly used in the early years of practice that our graduates are likely to see. And we try and ask our lecturers and leaders of other systems-based parts of the curriculum to really focus on a more limited list of medicines, because we don't want the students just to give up because they think it's an impossible learning task put in front of them. We need a lot more active learning. So I've pictured there a lot of what's going on. You might call it a lecture situation. Well, that's fine for signposting the way that we want the learning to go, but we have to contextualize that. And so we've worked really very hard over the last 15 years or so to make sure that although we do have lectures, that actually wherever possible that is actually made relevant by linking it to what's actually happening in the hospital. And as I'll go on to say, we've felt we've needed to try and sort of improve the practice of prescribing and make sure that there's e-learning support, and finally assessment, which I'll talk about. So these are some of the skills that we feel that it's important that we get across. So obviously be able to talk to patients, bottom middle, bottom left, actually writing prescriptions, and example of a paper prescription shown there. working with important tools that we use with medicines, such as nomograms, paracetamol overdose nomogram, which by the way was developed here in the University of Edinburgh about 40 or 50 years ago. Being able to make drug calculations, being able to mix drugs and work with intravenous solutions, understanding how to counsel patients about drugs such as inhalers, and being able to report an adverse drug reaction via the yellow card scheme. We of course don't report on paper anymore, it's all electronic, but these are the kind of skills which I'm sure you replicate in your medical schools, but are really important, I think, for we have a list of them in our curriculum. I think I've said this already, pharmacology in clinical context. So we try and deliver prescribing tutorials, case-based learning, ward-based teaching, and various other pre-prescribing. We have an online formulary for our medical students here in Edinburgh. So I think very much it's about trying to make sure that we are teaching pharmacology in context. And what we're trying to get beyond is this steep learning curve. This is where we were probably 20 years ago, and not necessarily in Edinburgh, but everywhere. The students hardly got any prescribing practice, and then they walk out of the medical school into the wards, and then they are prescribing probably more frequently than they're likely to do at any other time in their career. And as they get more and more senior, they tend to devolve the prescribing, certainly in hospital, back to the more junior prescribers, and the older and more senior you get, the less actual prescribing you do, and that is just a totally unreasonable learning. It's the wrong way to organize things, and so we need to skill up our medical students to be able to walk out onto those wards. And so here in Edinburgh we deliver therapeutics tutorials. We use the British Pharmacological Society's prescribing simulation exercises, near peer tutorials. That's where we've encouraged little syndicates of students to get together, and the more senior students and early graduates actually talk a little bit about their prescribing experiences to the medical students. And pre-prescribing is we've tried to reintroduce what I was very familiar with as a junior as a sort of medical student in the final year, which was actually acting up and writing prescriptions on hospital wards, which has become very difficult because of medico-legal issues. But we tried to put in place a scheme that would allow that to be happen with the appropriate supervision and sign-off. Here is the e-learning sort of program that Marcus and I are responsible for, that the British Pharmacological Society developed. It's called Prescribe. It's originally developed with e-learning for healthcare, with a grant from the National Health Service here in the UK. And nothing I would admit myself, so everyone's seen e-learning, but what we've tried to do is put together modules which help learners at a rate and pace and timing of their choosing to just understand a little bit more about clinical pharmacology and prescribing. So we've got about 60 modules like that are available for self-study with some knowledge checks, check learning as you go through. Before Marcus joined me and others at the British Pharmacological Society, we put together something called Prescribing Simulator, which we've now incorporated into the rest of what we deliver, and that this was an early attempt really to try and deliver more prescribing exercises to the students that they could do in their own time without endangering any students, but could nevertheless get prescribing practice. So there was a prescribing presentation on the left hand side of the a screen with case presentation, examination findings, and investigation with additional imagery if necessary. There was an electronic prescription box to fill out an electronic prescription in. They fill out their prescription, and then they get automatically scored on it and told just exactly what the best sort of prescriptions would have been in that circumstance. So that was just an attempt really to try and have a tool that anybody can use at any time just to upskill themselves with prescribing, and it's those principles are also sort of part of our assessment program. So I'd also like to acknowledge here, it's not just the UK that's been doing this sort of thing. There's some excellent initiatives both in the Netherlands, Australia, New Zealand as well. But I'd really suggest very strongly that if medical schools are not accessing e-learning resources of that kind, that I think our students find them very helpful indeed. An interesting question that we're all educators that we might ask, and I ask myself all the time, is does what we do actually make for better prescribers? And I think I've highlighted in that sort of graphic I showed you earlier on, it's quite a challenging question to answer. There's plenty of evidence from papers, small studies, most of them short-term, most of them under controlled conditions. So rather than seeing what's actually happening in the reality of the hospital wards, getting a few people in, giving them some learning and checking their before and after prescribing performance to a series of specific cases which have been developed. So it's helpful, but it doesn't really show us that in the longer term, if we make improvements in prescribing education, it really improves things on the ward. It doesn't dispute that, but it just says, actually, probably we need better evidence on this. And my colleague, Sarah Ross and Yoon Loke, did a big systematic review of this and showed that they concluded there's only moderate evidence from the literature that what happens in terms of medical school education is actually improving ultimate prescribing. Again, not because the studies have been done and the results are not very good, but just because there isn't actually very much evidence, and we can't gather very good evidence on prescribing practice of the people we wave goodbye to with their certificate as they leave medical school. And I think they concluded that we just need better assessments and better measurements. I think I've shown you a variety of this graph. What we really need to try and do is just get people on a better learning curve in the undergraduate sphere, and I think that's what I've been talking about. And since my time is nearly up, I just want to finish by highlighting what actually has been the most important part of all of this in the UK. It's probably been the most important thing that the British Pharmacological Society, and my fellow educators in the UK have done. And I would sort of strongly commend this to you. And I think we all recognise that assessment drives learning. And I think all of the other things that we've done with learning outcomes and learning programs, would be much diminished if we hadn't also put an assessment together that focused everybody's minds on that has to be passed to demonstrate basic competence to prescribe and use medicines. And there are lots of different kinds of assessments in prescribing. Some of them, at the simplest end of the spectrum, are just knowledge-based tests, which are cheap, reliable, reproducible. And this was how things were 15 or 20 years ago in our medical schools. Lots of simple knowledge-based assessments because they're easy to do. Really, the best we could do is observe real-world practice of our graduates. But the trouble is, it's just expensive. It's very difficult to to set an assessment of prescribing that's going to involve us literally taking our students out onto the ward, following them round for a morning or two, and watching what they do, because we just not got enough resource to do that. So we opted, in trying to produce a national assessment, to go to a medium fidelity simulation where we've got case materials that simulate the kind of challenges that are likely to be faced, but actually it can be taken in a controlled environment in a particular physical space. So that's really what led to us setting up the prescribing safety assessment. The prescribing safety assessment really was set up because we don't want people leaving our medical schools and starting to prescribe if they've not got basic competencies in medicines. But it's also very important because it's unified the standard across the whole of the UK nationally, and it's also helped us as educators in the different medical schools. And I'll show you some data on that, comparing the success of different medical schools in terms of coping with this national assessment. I apologize for those that already know the setup well, but our assessment really is based on 8 different stations. 40% of the marks go for writing new prescriptions, but because junior doctors do a lot of reviewing of the prescriptions others have written, there's a big section on prescription review, and all of these sections are really to test skills and knowledge that we in the UK at least feel are the different kind of things that we expect of junior doctors in our hospitals. So they have to do a bit of planning management, they have to provide information to the patients, but also to their colleagues. They have to occasionally undertake important calculations, which if they get wrong could have very serious consequences. They have to spot, manage and anticipate adverse drug reactions and interactions. They have to be able to know how to monitor the effects of the prescribing that they do, and they have to be able to interpret data such as drug levels, etc. And so our assessment is based around that. These are all the skills that we feel are important for people who are going to prescribe or supervise the use of medicines in a clinical environment. And the cases that we include in this assessment are nested in different settings: medicine, surgery, general practice, elderly care medicine, gynecology, pediatrics, etc. In the top part of the slide. Of course, there are lots of individual medical school assessments, but you can't really do something like this at international standard quality unless you amalgamate efforts and bring everybody together. So we've got about 100 item authors, senior, junior doctors, and increasingly pharmacists who write these question scenarios for us before they get anywhere near a final assessment. They go through various quality assurance processes. Those questions which are felt to be good enough to enter the 4 different papers available for the 34 medical schools annually are approved by the assessment board. We did that only last week in London, actually, for the assessments to be delivered in 2024. And there's a standard setting process by a modified Angoff standard setting. But very important, we also put a lot of items into practice papers, which, as I'll show you, are made available to students so they can actually practice and get feedback on their prescribing in the same way that I showed you with the prescribing simulator earlier on. So this is maybe what a prescribing case might look like. So there's a case presentation, examination findings, the investigations, and then there's a request to write a prescription to sort out something. In this case, the patient's breathlessness, and so there's an electronic prescribing form of the sort that might be encountered in hospitals around the in the UK. So you write your prescription and submit it, and it's marked automatically against a big matrix of hundreds of different answers, which we've anticipated might be given, and there is an automated scoring for that prescription. Here's a prescription review. So the patient presents with various problems, and they've already on certain prescriptions, and they get asked for a 2 questions: 2 most likely to cause daytime drowsiness, the 2 most likely to cause hyponatremia. And by the way, the ticks are not in the right box here, just before anybody tells me that the ticks are wrong. The daytime drowsiness ticks, of course, were meant to be with gabapentin and trazodone to score full marks. But as I've said to you, although all of our medical students have a final summative assessment to pass, they actually get 4 practice assessments where they can actually go through the questions, give their answers in their own time, and then they get automated feedback on those answers. And I think this is the most important part of the process for us, is that there are sort of practice opportunities people can go through, and they get some learning, when they get things wrong, a sort of classic active learning process. And it was so successful, this, and that the students, all of whom feed back to us about their experience with the prescribing skills assessment, they said this was almost the best part of the process. So Marcus, who's with me today, is very much involved in helping to sort of make available to medical schools in the UK, and quite a few abroad now, these banks of practice questions that help students with their learning and familiarity with prescribing. And just here's the same feedback for one of those prescription review questions. A really powerful way to learn that saves the faculty a lot of time, because I and my colleagues in other medical, we don't need to be around. The students can go through this, they can get some sort of experience approaching prescribing challenges, and get feedback in their own time without anybody in the faculty having to be involved. A very powerful tool that can be scaled up to large numbers. So, as I said last time, this is very much really a process of feedback within the profile that each of the candidates, the students, has within our system. They will get feedback on the assessments that they've undertaken, and they'll get scores in the different sections of the assessment. They also get feedback, as I've said, for the practice assessments that are just being used in a formative sense. So they get individualized feedback for specific answers for that. But very importantly, many of you will represent medical schools. We feedback the scores, of course, to all of the medical schools here in the UK, and they get to see where their students' performance compares with other schools. So that's a very powerful tool, really, for us as educators to sort of work out sort of whether our school and how our school actually compares with the others in the sector. The students feedback to us. They tell us what they think about the assessment, and also provide a lot of free text feedback. So that's very helpful for us in trying to sort of understand how they perceive their prescribing learning, not only the assessment, but their own prescribing learning pathways. And every year we ask them sort of how many prescriptions you've written in medical schools. And I'm pleased to say, over the years that we've been running the prescribing safety assessment, the PSA in the UK, more and more students, I think, are getting more and more prescribing done in the undergraduate arena. They're getting more prescribing practice. And of course, as Probably the same is the case in all the countries represented that I'm talking to. The junior doctors, the people who are just out of medical school, starting to prescribe. They can easily write 10 to 20 prescriptions every day on the wards that they work, and you can see that there are far too many students in our medical schools who've hardly written a prescription by the time they're faced with that particular task. So that is really a bit of a challenge for us. What have we achieved, I think, with the prescribing safety assessment? Well, we developed a novel online assessment system capable of delivering prescribing assessments to large numbers of people in multiple locations online. And indeed, we use that to deliver the assessment all over the world now to sort of various collaborating institutions, particularly in Australia and New Zealand, but also in countries in Europe as well. We've got a large bank of high quality case-based question items with automated marking and feedback. We produced an interactive learning tool, which I think gets round the problem that there just aren't enough people with expertise and an interest in pharmacology and clinical pharmacology to actually deliver all of the teaching that needs to be delivered. And I hope that just having that assessment there has stimulated better training experiences for our undergraduates. The future for us, we've been developing started to develop assessments for more senior doctors. Here in the UK, we've got pharmacists and other groups prescribing. So there are discussions about whether the assessment process that we've put together and learning process would be relevant for them. I've already said we've got collaborations in lots of different parts of the world, and we've got that linked e-learning program as well. So I think there's a lot going on. I've gone over 1 hour, and it's amazing that so many of you have stayed to listen to me, for which I'm very grateful. So I'm not going to read out all of those highlight points, because I'm sure you would think I believe all of them, and hopefully many of you believe those things as well. You know, we've written quite a lot about this over the years. So yeah, those are there are papers available should you be interested. So Olivia, I'm going to stop there. If there is any interest, I'll open up the British National Formulary and show people what that is like. So just let me know what you'd like me to do.
Right. Thank you very much, Prof. Simon, for a very comprehensive and insightful presentation on prescribing education to support and enhance prescribing safety. I think looking at the time, perhaps we'll allow Marcus to show us the BPS assessment platform first. Then we perhaps will go to the BNF if we have time. Marcus, over to you. Oh, we have one question. Perhaps we could just address that before Marcus shows the platform. Dear Prof. Simon, is there any data for pharmacy schools and pharmacists?
Great question. So there is, yeah. Sort of Marcus and I have worked with pharmacy schools. We did actually a funded study of pharmacy schools where we worked with most of them about 2017, 2018. So we do have data on pharmacy schools in general. Just to there are papers out there, so if you just sort of look up, there are papers out there. But the pharmacists do very well, of course, as you'd expect, because they spend almost their whole curriculum focused on medicines, whereas medics have got a lot of other things to do. I think the areas of our assessment the pharmacists don't do so well on is planning management in the clinical arena. Data interpretation, because they don't do quite so much of that in relation to clinical cases. But we've changed our pharmacy curriculum, or our expectations. The regulator what expected pharmacists, all pharmacists graduating from 2025 onwards are expected to be prescribing ready. So we are still hoping that I don't think they've made a decision yet, but they obviously are therefore going to need to have some kind of assessment of the sort that we have for medicine to decide whether people are in fact prescribing ready. And I'm obviously hopeful that they might conclude that we should bring all the assessment together, and the medics and the pharmacists should have the same assessment. So if anybody's interested particularly in pharmacy, quite happy outside this seminar to be involved in a dialogue with them.
Thank you, Prof. Simon. Over to you, Marcus, to show us the BPSA platform.
Thanks, Olivia, and thanks, Simon, for a fantastic talk. I'm just going to give a quick, hopefully, 1 second, I'll share my screen. Hopefully you can all see that, yes?
Yeah.
Hopefully that's sharing fine with you. It's fine. So I just wanted to quickly show the platform from the student's perspective. So I'm currently logged in as a student, and at the top we've got the practice assessments, which Simon mentioned before, and below that we've got our e-learning collections. So we have 2 e-learning collections. We have the prescribing skills, which has 27 individual sessions within it. And then we've also got clinical pharmacology and therapeutics, which has a further 26 sessions. As Simon mentioned, these can be completed by the students independently by themselves. They can work through this content as and when they have time. And as you can see here, one of these sessions here has already been started, 25% completed, and we can continue to work through that session as we come back to it. So I'm just going to quickly open one of these up just to show you how they look. And we can see, obviously, it's been authored by Simon himself. So we've got a table of content to begin with here. And to simply start this session, we hit the Start Session button. And as we can see, we've got a quick summary of the current session. We can quickly open content, so we can see an overview of the content we're going to work through on this right-hand side here. And we can also take any notes that we wish to take as we work through the content alongside here as well. Navigate through the content, it's simply forwards and back arrows at the bottom here, so next and previous. And as Simon illustrated in his talk, we have clearly defined learning outcomes set for each of these learning sessions that we have within the platform. So as we work through, we've got some text on the left-hand side, and images as we go through. So I'm just going to creep forward, and we can see fairly standard e-learning content, as Simon alluded to in his talk. And then I'm just going to skip forward and move forward through to one of the knowledge checks, just to show you how those would work. So here we have the knowledge checks, which are throughout the content, just to make sure that as we go through the content, we've understood what's been delivered to us. So these allow us a moment to reflect and just to check and embed that learning that we've gone through. So I'm just going to answer this randomly, just in the essence of time. And we can hit submit, and we can see we get immediate feedback on whether we're right or wrong. So here we can see not quite the right answer, which is unsurprising since I answered it so quickly. We can either retry that, or in this case, I'm just going to reveal the correct answer here, and we can see we get some immediate feedback on that as well, and the correct answer. And once we've completed the knowledge check, then we can continue to work through the e-learning content as well. So that's just a quick overview of the e-learning content. I'm going to go back now and show you one of the practice assessments. I appreciate Simon showed some of this previously in his presentation, but just to show you how that works in actuality. So here we've got a demonstration of item types. So this is just one of each of the 8 different item styles we have within the platform. So the 8 different types here. And we can see, you're probably familiar with this. This is the one that we saw a little bit earlier that Simon showed in his presentation. So just to show you a few more of the features within the platform. So we have a list of abbreviations built within the platform. So any abbreviations that we may use within the questions that we're asking, you can find those lists of abbreviations up here. We do have access directly from within the platform to the BNF. It is an open book exam. In the UK, we can access the NICE BNF. Outside of the UK, then you may need access also to Medicines Complete to provide access to the BNF, so you can look at that whilst answering the questions. We also have a built-in calculator for some of the data questions within the platform. And then we've got an assessment dashboard, so we can see where we are within the assessment, any questions that we may not have answered yet, or any that we may have been unsure of when we answered them, and we may have marked to go back for review. We can also add additional information. So in this case, we've got the case presentation that Simon spoke about earlier, and then we've also got a chest X-ray, which we can open up and pop up as a larger image here, and we can see different information as we go through. In terms of answering these questions, all we do is start typing in first few letters of the drug, and it will bring up all of the potential options for drugs that contain those 3 letters. So in this case, I'm going to just select the furosemide. We then need to enter the correct dose, in this case 50 milligrams. So again, as soon as we start typing in 50, it will give us all the possible options that we could answer. And then finally, we can enter in the route, in which case intravenous. So I'm going to put that in there. And that's our completed prescription question. Just going to move forward onto the next question type. So again, this is one that you saw earlier. So here we've got a prescription review, and we just have to select 2 prescriptions from each of these lists. One that's contributing to drowsiness, and that's one that's contributing to hyponatremia. So I'm going to steal from my crib list that I quickly wrote down earlier when Simon was going through this. So hopefully I'll get this one correct this time.
Yep.
And we'll mark that one for review for later. And then we have also sort of single answer questions as well. So in this case, this is a planning management question, and they're being asked to select the most appropriate management option at this stage. So again, I'm just going to choose that one randomly. I'm not going to go through each of these questions just in the essence of time, but I'm just going to end the assessment, and I'll quickly show you how the feedback looks when you go back into the assessment after you've completed it. So I'm just going to click End Assessment, and we can see a few that we haven't answered so far, one that we did mark for review. We're going to end that assessment now. And then we can see this is the practice assessment that we just took, and we can look at our results. So we can see immediately, as Simon mentioned before, we get an immediate score for that, those assessment that we've done. We can also go straight in and look at the feedback on a question by question basis. So we can see for this first question, the feedback was correct. The medicine dose root score was correct, and we can see feedback for each of those individual questions that we've gone through. Skip forward onto the prescription review, and again we can see we've got that correct, and again we've got individual feedback for the answers that we've given for those questions there. And then just to finish, we'll move on to the last one. So in this case, we've got the various different options. You can see that I chose an incorrect answer here, and we can see what the correct option was. And for each of these, we have individual feedback showing for each of those individual answers that we could have given as to why that was correct or why that was incorrect. So it really is, as Simon said, a really powerful tool, because it allows the students to go in, they can practice these assessments, they can see the scores that they've got, but it allows them also to reset those assessments and take them again. So it's a powerful tool to allow the students to embed the understanding as they've gone through. So I'm going to exit that now. Hopefully that was a relatively quick overview. I know we wanted to leave some time for questions at the end, Olivia, so hopefully that was a helpful brief overview, and we can now open it up for some questions. I can see there are already some waiting for us, and I'll stop sharing.
Thanks very much, Marcus. Thanks for the presentation of the platform. Yes, we do have one more question. It says, what kind of medications are the pharmacists, nurses, and medical assistants allowed to prescribe?
So they are able to, well, it depends, but if they've been through the full prescribing course, then legally they are, like myself, entitled to write prescriptions for all medicines which are legally prescribable in the UK. But like myself, there would be a problem if we actually started prescribing outside our recognised knowledge and competency. But if you're a legal prescriber in the UK, then you are able to prescribe really from sort of all of the different sort of potential prescribing options that are available. I think it's important to make that point. And indeed, Olivia, I don't know whether it's of any interest to you, but here is the British National Formulary, and the reason that the British National Formulary is so important, I think, both for our learners and also for those working with the resources that Marcus and I are talking about, is that everybody in the UK has access to the British National Formulary. It's the go-to resource if there is a question about a particular medicine. It's divided up into a drug list of interactions, treatment summaries for various conditions. If I'm wanting to sort of prescribe various medicines, then this would be where I would go for further information sort of about those medicines. Typical example here, amlodipine. So they're all set out in a treatment monograph with drug action, indications and dosage, contraindications, cautions, interactions, side effects set out, common, very common, uncommon, rare, and very rare, both for the whole class of that drug, but also for the drug itself. Information about pregnancy, breastfeeding, etc., directions for use, and it's a very easy search. So it's a standard drop down. So if we then wanted to go on to bisoprolol, then just it's a straightforward type, and then you're into the bisoprolol monograph. There are a whole series of treatment summaries on various areas, such as treating acute asthma. It's very easy. Slightly confusing thing for you is that this is the British National Formulary as made available through the National Institute for Health and Care Excellence. There is a version which is sort of available via directly the Royal Pharmaceutical Society through Medicines Complete, which has other drug resources, but for most people in the UK, they have to pay for that, whereas the British National Formulary via NICE is openly accessible for everybody in the UK, patient, doctor, pharmacist, etc. So I think it's a fantastic resource, and I'm obviously not knowledgeable enough to know whether you all enjoy a similar high quality national resource, but it's really been very valuable for what Marcus, I, British Pharmacological Society, and all of our sort of teaching institutions do, because it means that everybody knows the resource that they will have available throughout their prescribing career. And as Marcus implied, and I forgot to say, that all of our candidates doing the prescribing safety assessment, or we call it the prescribing skills assessment, in collaborations overseas, have access to the British National Formulary, or expected to have access to it, because they would have access to it as prescribers. So I don't know whether you want me to show anything more about the formulary, Olivia, but it really is a fantastic resource, publicly available for everybody in the UK.
No, yes, thank you, Prof. Simon. That was a brief but yet clear overview of what the British National Formulary is. And for those of you in our audience who are interested in this, it is available via, as mentioned by Prof. Simon, via the Medicines Complete resource, which if you're interested, feel free to contact us by emailing marketing@igroupnet.com. And on the Medicines Complete platform, apart from the BNF, there are also other reliable drug resources like the Stockley's Interaction Checker, Martindale's ADR Checker, the Drug Compatibility Checker, Drug Monitoring Checker, and there are also many new updated formularies like the palliative formulary, the intensive care formulary, and so on. So because of time, we're not able to show all that today, but do feel free if you're interested to follow up with us, or you could email us. One more question, Prof. Simon. There is a trend towards electronic prescribing for various reasons. Question number one, how has this influenced the teaching and learning of practical prescribing? Question number two, how might have this influenced the prevalence of prescribing errors?
Well, thank you to Mike for that question. Very insightful, as I'd expect from Mike, who I know well, although I didn't ask him to plant that question. It's very important because in the UK, when we started this process off, and I should point out Mike has been involved in that himself. Yeah, when we started this process, everybody was prescribing on paper, at least our graduates in hospitals were. Electronic prescribing is now widely embedded, so it's certainly over half now, I think, of hospitals. And I think that has been important because I think it has given us a new challenge, because prescribing electronically is slightly different to prescribing on paper, but also I think it's been probably quite good for the prescribing safety assessment, because actually we made a bold move in 2010 to set out to deliver this assessment online, because most people were actually prescribing on paper then. But actually, now that most people are prescribing electronically in hospitals, then actually the whole process of the prescribing safety assessment works very similarly. So I think it has I think it's been to the benefit of what we do, but I think, as Mike knows, it's also produced some challenges for education, because electronic prescribing does introduce potentially new errors as well as solving a lot. And indeed, the second part of his question was around the prevalence of prescribing errors. And actually, we could talk for an awful long time about that. We know that electronic prescribing has got rid of a lot of errors, misunderstandings, and poor communication with medicines that existed before. But of course, it has introduced some new possibilities by getting large factor dosing errors is possible. Just picking drugs out of a list and just clicking on the wrong drug, an easy slip or lapse to make for people who work with large, long lists. How often have we been asked on booking an airline to say which country our passport is issued by, and accidentally tick the United States instead of the United Kingdom? So that, which are both right at the very bottom of a very long. So it does introduce some potential new errors. And the trouble is that when you're writing out a drug name, you've got, that's an active, conscious effort you do, and you can get the drug name wrong, but you're unlikely to write out in longhand amlodipine when you actually meant atenolol, or vice versa. So it does introduce new errors as well. But I think, Mike, we all know, and I suspect everybody that's listening to this will probably increasingly be using electronic prescribing. It's the future. It helps with so many other things. You can overlay decision support on top of it as well. So we could talk for a long time about those really good questions, but I think I'll leave it at that, Olivia.
Thank you very much, Prof. Simon. So just to wrap up, for anyone in the audience who are or listening to the recording, who are interested to either have a closer look at the BPS assessment or Medicine's complete resource, feel free to write to marketing@igroupnet.com as shown on this slide, or if you prefer to contact our representatives from the different countries, you could do so as well. I would encourage everyone to provide feedback, and in the feedback form also, you get the opportunity to indicate whether you would like to be followed up or you would like to receive a 1-month free trial of any of these resources. I think that's all. Thank you very much, everyone, for taking time and staying so long with us in the afternoon. Thank you again, Prof. Simon. Thank you, Marcus. And all participants. Thank you all. See you again soon.
Thank you.